Hello, Jamie Raymond here, and in this video with a clickbaity title, we're going to take an introductory look at the psoas and the single most important thing that most docs fail to recognize. Perhaps no other single muscle has had as much written about it, or as many gadgets designed for it, as the psoas, and yet despite its notoriety, there is one crucial aspect about the psoas that goes largely unrecognized. So what's the matter with you? Sorry, my wife made me put that in. And that is psoas muscle inhibition, when one or both psoases, how do you say the plural again, have lost their ability to fully engage. If you've watched some of my other videos, you know that muscle inhibition represents a reduction of a muscle's activation and force production stemming from an alteration of the efferent signal to that muscle. Now there are several scenarios as to what exactly is disrupting this efferent signal, but our focus will be on arthrogenic muscle inhibition, whereby the inhibition results from swelling, damage, and especially our focus, subluxation of a joint associated with that muscle. AMI is known to occur thus far in the quad secondary to knee injury, and the glute max secondary to a hip joint effusion, and the soleus, peroneals, and gluteals after ankle injury. Even when your patients are doing appropriate exercises, an inhibited psoas is just not going to fully respond. This is pretty much my working definition of inhibited muscles. They just don't respond appropriately to exercise and use. So arthrogenic psoas inhibition represents basically the same biomechanical issue, joint dysfunction at or near the muscle's attachments. Technically, while it could be the origin or the insertion onto the hip joint, it's much more commonly relates to problems at the origin of the lumbar spine. It's actually my favorite piece of anatomy trivia, how high up into the spine the psoas actually attaches, up as far as T12. In your report of findings, this is a great way of linking lower spine and core dysfunction into pelvic, hip, and lower extremity injuries. So why does psoas muscle inhibition matter so much? The answer lies in the psoas' varied actions. It functions at times, obviously, as a hip flexor, but also as a spinal stabilizer and even a hip joint stabilizer. So consequently, if psoas is suffering from inhibition and has a reduced ability to activate and produce force, you're going to lose some hip flexion, lose some spinal stability, and lose some hip joint stabilization. These are all pretty critical functions. The classic view on psoas focuses mainly on it being tight, and how, for example, this will increase lumbar lordosis and contribute to low back pain. While I don't disagree with that, I would point out that there is much less talk about psoas weakness and almost no recognition of psoas inhibition. By the way, as a clinical side note, I'll also mention that due to psoas inhibition and the effect of synergistic dominance, the other hip flexors are frequently just as tight, if not tighter, than psoas itself. The next few times you're doing manual release of the hip flexors, take note of which muscle you're actually on. I know I find especially the lateral portion of the iliacus is frequently the tightest of the bunch. In looking at those individual actions, when you lose some of psoas' contribution to hip flexion, not only do you get tightness of those flexor synergists, on the other leg you also get hip extension limitation, which then loads the rest of the posterior chain. This will show up in the gait cycle. Distance runners often describe this to me as feeling like they're dragging their leg along, and their symptoms will often be worse going up an incline or in hikers going uphill as opposed to downhill. In gait analysis, you can see deviations from the sagittal plane, showing up, for example, as a heel whip. Some combination of these gait deviations and the limitation of the hip extension means that psoas inhibition is frequently an underlying factor for Achilles issues. And to top it all off, the altered landing can also improperly load the foot, leading to foot subluxation, or even in worst case scenarios, potentially even stress fractures. As you know, lower spine and pelvic stability has a lot to do with the integrity of the core muscles. I like the analogy of the core as a compression cylinder, with the abdominals forming the walls of the cylinder, the diaphragm the top, and the pelvic floor the bottom. In this analogy, you can see where psoas helps to maintain stability with an appropriate level of compression of the lower spine. Obviously, weakness of any of these muscles compromises the spine and pelvis. However, of these muscles, psoas and also QL are most prone to becoming truly muscularly inhibited, more so than, say, the abs, presumably because of the psoas' spinal attachments, which for a variety of reasons that we will discuss can become subluxated. It's important to differentiate between psoas inhibition and general core weakness. Generally, weak patients just need to put the time in with the right exercises to get stronger. However, again, you can have people who are doing the right exercises, and yet psoas is still inhibited, not responding, and destabilizing the system. The third potential effect of psoas inhibition is hip joint instability. Until recently, most of the research on psoas went back and forth between its role as a hip flexor versus a spinal stabilizer. But when brushing up on the latest research for this video, I came across an interesting review study published in 2020 which demonstrates that psoas also has a role as a hip joint stabilizer. I was excited when I found this because I think it explains an interesting clinical phenomenon that I've encountered, something I had to piece together over the years, not based on research, but just trial and error with real patients. What I noticed was this: there were times when I could seemingly fix muscle inhibition of the local hip muscles, adductors, glute max, glute medius, by first addressing psoas inhibition. The opposite of this was also true. There were times when I couldn't fix glute or adductor inhibition. When psoas was inhibited, all of the other hip muscles associated with the hip joint just seemed to kind of fall apart. Based on this latest research, what I now believe is something along the lines of this: when psoas is inhibited, you lose some hip joint instability, and like a domino effect, the adductors, the glute max, the glute medius, all become secondarily inhibited. So by addressing psoas inhibition first, stabilizing the hip joint, the other hip muscles can then do their thing. So how does psoas inhibition show up symptomatically? Well, let me count the ways. You can get low back and hip pain, obviously. Due to synergistic dominance, you get other hip flexors tightening up, which can show up as something like a myalgia paresthetica. Rectus femoris can get strained proximally or show up as an anterior knee pain. Sartorius can show up as medial knee pain. As described, you get gait alterations, which can affect the Achilles or the foot. So essentially, psoas inhibition can be involved in some shape or form with pretty much anything in the lower half of the body. So just how common is psoas inhibition anyways? While I don't have exact numbers, I can tell you it's not rare, and in fact it's pretty common. We're currently in the recruitment phase of our next study at the University of New England, looking this time at the hip adductors, amongst other things. For this study, we're intentionally excluding subjects with hip flexor weakness, as it would likely askew our adductor measurements as we just discussed. We're finding that about a quarter of the people we screened have psoas inhibition, and these are mostly young, relatively asymptomatic DPT students at the school who, if anything, are more likely than average to be hitting the gym. At our offices, amongst symptomatic patients with low back, hip, and lower extremity complaints, that number is closer to 50%. So at least half of these patients have a key low back and hip stabilizer / hip flexor that has lost its ability to fully engage. And I don't think this number is unique to just our offices. So next we're going to answer the question, how does psoas inhibition occur? Well, the short answer is subluxation, most commonly at the origin of psoas in the spine. While psoas attaches up as high as T12, in reality subluxation as high as T10 can disrupt that efferent signal and inhibit psoas. One of the issues we face in treating psoas inhibition is that subluxations at the psoas origin, especially up at the TL junction, can be difficult to detect, much less adjust. Over the years, as I gained an appreciation for just how commonly psoas inhibition occurs, I realized how frequently I was missing out on the fact that these subluxations are even there. And as I learned more and more just how significant psoas inhibition is, and how often it plays into a wide variety of injuries, I spent years perfecting not only the best adjustments for these subluxations, but also the palpation skills to find them in the first place. I'll share what I learned in the psoas inhibition treatment protocol. I would have loved to be presenting this to you in the form of a study showing how thoracolumbar spine manipulation helps to improve psoas activation and force production. Unfortunately, there are a few hurdles that make this not feasible, at least for now. Psoas activation measurements require the placement of fine wire into the muscle, as it's too deep to use surface EMG. I think we'd have trouble recruiting enough subjects, and I'd feel kind of bad placing fine wire on control subjects who really get no benefit from their participation. Last but not least, there's cost. In our hip abductor study, we asked one of our subjects jokingly how much we'd have to pay her to place a fine wire into her psoas, and she quoted us $100. This compared to the $15 she was receiving for the hip abductor study. Multiplied by the 40 subjects we need to power this study, that adds up to quite a bit. So the next question becomes, why do these thoracolumbar subluxations that inhibit psoas happen so frequently? Well, general rule of thumb is that subluxations that are pronounced enough to be causing muscle inhibition are usually going to have an associated stability or mobility deficit causing or perpetuating that subluxation. So one explanation for psoas inhibition is that the muscles that should be keeping the thoracolumbar spine stable, namely the core, are weak. This can all become somewhat of a chicken or the egg thing because we just mentioned a moment ago that psoas itself is a spinal stabilizer. However, the psoas needs a stable spinal origin for it to function properly, and if the other core muscles aren't up to par, this can allow the thoracolumbar region to subluxate, and then psoas becomes inhibited. Now, it could just be that your patient needs to do more planks. However, let's assume for a minute that they do appropriate core work. They work out with a good trainer, they do boot camp classes or Pilates, etc., and their psoas is still testing inhibited. In this situation, I found that psoas inhibition can be a red flag for a more specific and problematic form of core weakness, an isolated weakness of the transverse abs. The TVA, we used to call them TA at our office until we realized that asking your patient to strengthen their TNA probably wasn't a good idea. But the TVA are prone to weakness after low back injury, lumbar disc herniation, or maybe an abdominal surgery such as a C-section. In these cases, TVA can become disconnected, meaning somewhere along the line it's lost its ability to fire. In these cases, you can't just tell your patient, do more planks. You'll have to have a means of bringing awareness to the TVA deficit and educate your patient on the best way of reconnecting to it. Now, assuming that your patient does have adequate core strength and stability, including TVA, the other most common reason the thoracolumbar spine will subluxate and inhibit psoas would be a mobility deficit of the surrounding musculature. The usual suspects would include the paraspinals, QL, and the obliques. These muscles and their associated fascia are frequently the site of scar tissue in the form of adhesions, which can restrict and ultimately subluxate the spine. This concept is important. Subluxations don't happen in a vacuum. If you have a joint that's subluxated enough to make the body want to inhibit a muscle, especially one as crucial as psoas, there's got to be a reason. One of my biggest breakthroughs in the development of our protocols was the recognition of just how often underlying mobility deficits factor into subluxation and consequently muscle inhibition. One of my light bulb moments came in the weeks after returning from a spinal ART seminar and realizing just how often these adhesions were present at the same level as stubborn or recalcitrant subluxations. The next big recognition was that adding I-stim prior to the ART made it easier to find and ultimately get rid of these adhesions. One final question to answer, where do these adhesions come from? Well, you will occasionally see them associated with things like a scoliosis or past surgery, but the most common means is by past injury, especially in our athletic population. People are forever hurting themselves, especially these days, and we have so many ways to do it. And if you look at the mechanics of a lot of injuries, the lower thoracic region bears the brunt of many of these impacts. This is why we have ribs, right? To keep everything inside protected. However, while your liver stays safe, these impacts leave a mark in the form of adhesions in the muscle and fascia. If you don't already, start asking your patients about their past trauma history. You might be surprised by how often they suffered a traumatic injury sometime prior to the onset of their current complaint. Make sure to ask the follow-up question, how did that happen? So for instance, if this guy tells you that his only past injury was a wrist fracture 2 years ago, it wouldn't seem to relate to his current complaint of hip pain. But if you ask him how that wrist injury happened, and you get the full story, and he remembers that, oh yes, I also bruised my right lower ribs, and yes, that was about 3 months prior to the onset of my hip pain, it helps to flesh out the story. The tricky part to this is that there is literally no time limit for adhesions. I've documented them as long as 75 years after a known childhood injury. I cover that in another video. I'll offer a quick case study as an example of how past trauma plays into a current complaint. Again, Psoas inhibition is not a rare finding, especially in symptomatic patients. It happens all the time. I picked this case just because he happened to literally come in yesterday and it's fresh in my mind. So we have a 28-year-old healthy ski patroller with a chief complaint of low back pain over the past month associated with lifting patients during rescue training. His past history included low-grade chronic hip tightness despite doing yoga regularly. Also a chronically sore right Achilles, which he managed mostly by limiting his running. And he denied any past trauma despite several inquiries. In his exam, neurologically seemed pretty intact, didn't seem to be any disc involvement. L5 and the sacrum were pretty locked up, which seemed to match up with his pain pattern across the belt line. And core strength was good. With manual muscle testing of his hip and low back muscles, we found that the right psoas was inhibited. Based on the right psoas inhibition, I scraped the corresponding region and found, whoa, a ton of adhesions. It was at this point that he remembered that yes, he had fallen off a trailer 10 years ago and landed on that area, and it took several weeks to recover. His quote was, "But that was 10 years ago. It doesn't matter, the adhesions are still clearly there." I will also add the fact that he had a nagging right Achilles injury was my first clue that there might be a right psoas inhibition. So this leads to my final thought for this video, and that is how learning to diagnose or recognize psoas inhibition and muscle inhibition in general often makes the difference between managing an injury versus truly fixing an injury. So for example, with a previous case study, I'm sure you would have identified the L5-S1 subluxation, adjusted that, and gotten him feeling better in short order. But how many would have identified the psoas inhibition or the thoracolumbar subluxations and adhesions from the old injury creating this inhibition? Well, until someone figures out this fuller picture, this guy is destined to become a maintenance patient, the kind that comes in every 3 to 6 months when his back starts feeling tweaked and he gets adjusted, and yeah, see you in another 3 to 6 months, and this is great, he has less low back pain and functions pretty well, and you ART and tape his Achilles when that gets flared up, and that helps a bit, allows him to run another few miles a week. But what if you're the doc who does figure out the fuller picture, determines that he has psoas inhibition, and connects the dots back to the old injury and these adhesions and addresses that, and now he's good, truly fixed, no back pain, no more recurring episodes. And to boot, you fix his Achilles without even touching his calf. And now he can run as much as he wants. Well, you may lose a maintenance patient, but guess what? You gain a walking, talking advertisement for your practice, because he's going to tell his fellow ski patrollers and his running buddies and anybody who thinks that you can help. I guarantee you that if you master these concepts, you'll spend less time managing injuries and more time actually fixing them. As always, thanks for watching, and I hope that we've added to what you know. If you like this video, please hit the like button, and if you subscribe and allow for notifications, we'll let you know when the psoas inhibition protocol video comes out, which will cover the specific treatment algorithms I've developed to help you get to the bottom of your patient's injuries. Take care.